to learn and what we can learn. Dr. Bancalari needs no introduction, I'm sure. He basically defined BPD for the modern ages. Look up any definition of BPD and you'll have his name next to it. As usual, type your questions on the chat box, as Rahul said, for us for Dr. Bancalari to address at the end of the talk. And this talk, with his permission, will be recorded and uploaded onto our WhatsApp group. So if you're not on it, give us a yell and we'll put you on. All right. Thank you so much, Eduardo. Over to you.
Is that okay? Is it showing?
Perfect. All yours.
Okay. So I would like to start by thanking Julio A. and Rahul Prasad for organizing this series of lectures and giving me the opportunity tonight to discuss one of my favorite topics. I will just start clarifying, I don't work at Miami Children's. I work at the University of Miami Jackson Memorial Medical Center in Miami.
Oops, my mistake. Sorry.
Different institutions, but it's okay. I don't have any disclosure to make, except that we have funding from Project Newborn, a philanthropic organization, and NIH for a prematurity-related ventilator control trial. So what I'm going to do in the next 40, 50 minutes is first to talk a little bit about what is BPD. After that, I will discuss some of the pathogenic factors for BPD, both antenatal and postnatal. And after discussing the mechanisms of lung injury, we'll then briefly discuss some of the possible preventive strategies to reduce the incidence or the severity of bronchopulmonary dysplasia. So BPD was described now almost 55 years ago by Dr. Northway, Rosanne, and Porter. And essentially what they observed was that babies who were started to be mechanically ventilated, this was at Stanford in those years, start developing a significant radiographic and morphologic changes after prolonged mechanical ventilation. I have to remind all of you that this was the beginning of respiratory support before surfactant, before antenatal steroids. So the settings of these babies were incredibly high, very high pressures, very high oxygen concentrations. So let me see if I can move this. No, I cannot move, so I cannot even see let me see. Okay. So why are we all so concerned about BPD? First, because it is a very common, it's one of the most frequent complications of prematurity, especially in the extreme premature infants. Second, BPD is associated with higher mortality. And especially, it's also associated with long-term morbidities that include lung, cardiovascular system, and brain, unfortunately. This severe lung respiratory failure prolongs the hospital stay. This induces a separation of the baby from their family, unless you have the luxury of having a room where the parents can stay day and night, and has very high resource utilization. So these are babies that have a very high cost. I think that the most intriguing part of BPD is that clearly is the example of multifactorial disease. And that's why it's very difficult to prevent. And that's why we have such a high incidence. And that's why I think we have to forget about the magic bullet. I think that this is a disease that requires a complex approach because it's a complex disease. So here you have on the left, the radiographic picture of the typical BPD that was described by Northway. We call it original BPD. And you can see that there is a severe derangement of the architecture of the lung, cardiomegaly secondary to cor pulmonale due to pulmonary hypertension, And the histology in the bottom reflects what is the typical picture of these infants: severe emphysema surrounded by areas of collapse, and marked changes in vessels and airways where there is hypertrophy of the smooth muscle. This was again the initial description of these babies. Now, after the introduction of antenatal steroids and surfactant, the management of the baby with high membrane disease became easier. We don't have to use the very aggressive respiratory support that we had to use before these therapies were introduced. And today, then, most of the babies that develop BPD, we call them new BPD or milder BPD. And as you can see there, it's more a homogeneous picture. We don't see these huge areas of emphysema as commonly as we saw them before. And the real phenotype in this phenotype is decreased alveolarization. So these babies, instead of having this gross derangement of architecture, what they have is decreased number of alveoli and capillary. This reduces their diffusion capacity, and this explains then why they require high oxygen concentrations also for a long period of time. Now, these are the two extremes. Obviously, things are not black and white. There are many babies who fall in the middle at different degrees of severity. And the trend has been shifting into these new milder forms of BPD that fortunately has a much better outcome than the original BPD. These are the incidence of BPD, total BPD in red. And in green, you can see the incidence of severe BPD defined here by oxygen more than 30% at 36 weeks. And you can see that the severe BPD in the last 10, 15 years is less than half of the total BPD. So the majority of the infants today, fortunately, have this milder form of BPD. So what is happening is that progressively we're taking care of more and more immature infants, babies born at 22, 23, 24 weeks, clearly border of viability. And at this stage, the lung development is still at the canalicular or saccular stages. They have not even begun the alveolarization. So easily understand that a lung that is supposed to stay in utero producing fluid and barely moving and without seeing any gases, all of a sudden is exposed to extrauterine environment where the tidal volumes are much larger. The alveoli are inundated by gases, many times gases with very high FiO2, and therefore produce a significant amount of oxygen toxicity or can produce oxygen toxicity. And they are usually, these lungs, invaded by microbes that also produce inflammation. So it's not surprising that this change in milieu ends up altering the progression of development, altering the development of alveoli and capillaries in these very immature lungs. And essentially there is a delay, not total cessation, but there is a delay in the progression of alveolarization, essentially leading them to a lung with decreased number of alveoli, decreased number of capillaries, and many times also with marked changes related to inflammation. So in order to prevent any disease, we have to understand the mechanisms of these diseases. That's the only way we can develop an effective strategy for prevention. And in BPD and alteration of lung development of the very immature lung, without any question, premature birth is the main substrate of this maldevelopment. Placental dysfunction is becoming also a very important antenatal factor that alters the progression of lung development. So maternal hypertension and intrauterine growth retardation clearly increase the risk of BPD. Infections, a very important factor also related to chorioamnionitis or uroplasma colonization that most of the times is asymptomatic, will also increase the risk of BPD. And then other factors such as maternal smoking, vitamin D deficiency, and genetic predisposition are also antenatal factors that increase the risk of bronchopulmonary dysplasia. Once the baby is born, probably the most important factor is severe RDS, severe respiratory failure, that requires aggressive invasive respiratory support. And at this point, then, increase in peak inspiratory pressures, high tidal volumes, and high inspired oxygen concentration are clearly associated with a higher risk of BPD. Once again, postnatal infections are a significant factor that increases the risk. Patent ductus arteriosus, due to with a significant degree of pulmonary overflow, produces also alteration of the capillary endothelium and has been associated with a higher degree of alteration in lung development. This has been shown in monkeys, and is also clearly shown in patients where the ductus plays a significant role as a risk factor for BPD. There is data also from Denver originally, and now this has been supported by many other papers that show that early pulmonary hypertension is more common in BPD, and this may be because these babies have, as I mentioned before, a pulmonary vascular maldevelopment, usually associated with maternal hypertensive disease or other placental dysfunction syndromes. Finally, nutrition deficiencies, such as vitamin A deficiency, protein deficiency, can also increase the risk of bronchopulmonary dysplasia. This is a paper that we published a couple of years ago, showing the significant role that that maternal hypertension, preeclampsia, plays in the development of bronchopulmonary dysplasia with an odds ratio of more than 2. And you can see also here that babies that are small for gestational age, babies with PDA, and babies who require mechanical ventilation very early on also have a higher risk of bronchopulmonary dysplasia. The other risk factor then that we mentioned is infection, and this is very old work from Alan Job's group. It may have been obtained in Australia, actually, where they showed that the injection of endotoxin in the amniotic fluid of sheep produces also a clear inhibition of alveolarization compared with what you see in the upper portion of this slide in a normal lung. I have to remind you also that the exposure to betamethasone in the fetus in high doses can also inhibit alveolarization and end up with a phenotype similar to BPD. Uroplasma colonization occurs with very high frequency in preterm infants. Actually, the lower the gestational age, the higher is their colonization rate with uroplasma. And uroplasma also has been associated, as you can see in this meta-analysis, with a higher risk of bronchopulmonary dysplasia. This is a relationship or a meta-analysis of studies where they have analyzed mothers with and without chorioamnionitis. And here again, you can see in the lower part of this slide that infants born to mothers with histological and clinical evidence of chorioamnionitis have a substantial increase in the risk of bronchopulmonary dysplasia. So colonization and infection, secondary to maternal infections, or also postnatal infections, increase significantly the risk of BPD. Obviously, every time that we suspect or we have proof of an infection in a newborn, the first thing we think is to start antibiotics. And unfortunately, although this is necessary in babies who are clearly septic, there is ample evidence that the use of antibiotics for colonization in neonates increases the risk of bronchopulmonary dysplasia and also increases the risk of necrotizing enterocolitis. So this is a double-edged sword. On one side, if the baby is really septic, we have to treat them. But on the other side, if we start treating colonization, we probably make the situation worse and not better. So the only alternative here, or the most effective alternative, is try to prevent infections, prevent colonization in these babies after they are born. And this is easily said, but it's not very easy to avoid infections in babies who are extremely premature infants, who have invasive ventilation and all sorts of IV insertions and so on. Without any question, the pathogenic factor that has been stressed from the very beginning in BPD, as I mentioned, BPD appeared after we started using mechanical ventilation in these infants, is the use of intermittent positive pressure ventilation through an endotracheal tube. This is a study from the neonatal network in Italy showing the increase in incidence of BPD as the proportion of infants who are intubated in the delivery room increases. They did a correction for confounding factors, and they concluded that every week of invasive mechanical ventilation in preterm infants increased the risk of BPD, the odds ratios of by 15 times. So clearly, mechanical ventilation has been and continues to be considered one of the main pathogenic factors of BPD. This is a paper from the Scandinavian countries that I think shocked everybody, because we were all convinced that mechanical ventilation was bad, but we thought that this was prolonged mechanical ventilation. Well, these authors showed in experimental animals, in sheep actually, that just a few breaths immediately after delivery with very high tidal volumes produce a significant damage in these lungs, with disruption of the alveolo-capillary membrane, with edema, with inflammatory markers, and significant alteration in gas exchange. So we really don't need prolonged mechanical ventilation. All we need are a few minutes maybe, or hours of aggressive, inappropriate mechanical ventilation to set the development of these lungs in an abnormal path and increase the risk then of bronchopulmonary dysplasia. Because of this association between mechanical ventilation and bronchopulmonary dysplasia, and there were many papers that showed that units that use less mechanical ventilation, in this case, Columbia University Babies Hospital in New York, had a much lower use of mechanical ventilation than two control hospitals in Boston. 75% of the babies under 1,500 grams were intubated at this time and mechanically ventilated, while at babies in Colombia, only 29% of the babies were ventilated. And the dramatic difference was that the incidence of bronchopulmonary dysplasia was substantially lower in the babies treated at Columbia University, again, suggesting that the use of mechanical ventilation plays a very significant part in BPD. After these observations, there were many randomized trials that I'm sure most of you are aware of, trying to prove, essentially, to demonstrate that the use of CPAP instead of mechanical ventilation immediately after birth was going to reduce substantially the risk of BPD. Unfortunately and surprisingly, the results were in the right direction. There was a lower incidence of BPD or death in babies treated with CPAP immediately after birth in all the studies, but not one of these studies showed a significant reduction in BPD. Only when all the studies are analyzed together in this meta-analysis, we can see that there is a significant reduction in bronchopulmonary dysplasia or death. So we were all very surprised to be unable to reproduce what we were all thinking that was going to happen based on the Columbia experience. And I think that there are many reasons why these results were not more significant. One of the reasons was that the babies who were treated with CPAP did not get surfactant, while all the babies who were intubated received surfactant. So it was not only CPAP versus invasive ventilation, but was CPAP without surfactant versus ventilation and surfactant. And that's why there were many studies after this, where instead of just using CPAP and not giving surfactant to these infants, babies were treated with the so-called ENSURE, intubation, surfactant, and rapid extubation immediately after the intubation. And with this strategy, the results were much more striking. The need for mechanical ventilation was substantially reduced by ENSURE. Leaks were lower, and the incidence of bronchopulmonary dysplasia, here defined at 28 days, was also much lower in babies who received ENSURE. So I think that today it's very clear that you cannot just use CPAP and leave those babies without treatment when they have RDS, and you have to use either ENSURE, or now in Australia and in Europe also, there are other alternatives, LISA or MIST, where the surfactant is administered to babies who are breathing spontaneously and who are not intubated. The surfactant is just administered through a cannula in a spontaneously breathing infant. So the issue with nasal CPAP is this, and this is also data from Peter Daggerville in Australia, that essentially reported these results from the network in Australia, showing the incidence of failure of CPAP in relation to gestational age. And similar to what was described in New York at Columbia, you can see that nasal CPAP is very effective in babies over 28 weeks. The number of babies who require intubation is relatively low, so you have a substantial portion of kids that will continue to breathe spontaneously, and you can keep them in CPAP. Unfortunately, if you look at the data below 28 weeks, you see that the vast majority of these very small infants CPAP, and at one point or another, they will require mechanical ventilation because of severe respiratory failure. So with CPAP, we have a situation where the population who is at the highest risk for developing BPD cannot be managed with CPAP alone because of poor respiratory control or severe lung disease that doesn't allow them to maintain oxygenation and gas exchange without invasive respiration. Here is then when a different alternative, a sort of intermediary between CPAP and mechanical ventilation, comes into play, and this is nasal ventilation, nasal IPPV. Nasal IPPV has been used now for many years, and there are a number of trials. Unfortunately, most of them are relatively small. And what it has been used as an initial strategy for support of babies with HMD, and you can see that some studies have shown a reduction in the need for intubation, while others, although beneficial effect, they still did not reach significance, and a good number of the babies, despite the use of nasal ventilation, required intubation and mechanical ventilation. Where nasal CPAP, the nasal IPPV seems to be more effective is after extubation. And here you have another analysis of 4 trials where nasal IPPV was used then after extubation to try to avoid the need of reinstitution of mechanical ventilation. And here you can see that the benefit is much more striking, highly significant in all these trials. I have to say that in these studies, many of them used synchronized nasal ventilation that unfortunately is a modality that at least in the USA, and I think that also in Europe, is not available these days because the ventilators that were used, the infant star, are not available these days for commercial use. What happens with BPD? So even when nasal ventilation reduces the need of intubation and helps extubation, the effects on BPD are much less consistent than the other outcomes. And although there are some trends, most of the studies, or all the studies really in this meta-analysis, did not show significant reduction in bronchopulmonary dysplasia. Unfortunately, again, most of the studies have used nasal ventilation that is not synchronized, and you can see that the numbers of babies included in these studies, except for the one done by Kirpalani here in the US, the other studies are all very small. So I think that the effectiveness of nasal ventilation to reduce BPD is still open for proof. Despite the fact that, again, there is not very strong evidence that nasal ventilation reduces BPD, because of the reduction in the need for mechanical ventilation, you can see this data from Dupré 1 year ago that shows very clearly that the use of nasal ventilation has been increasing dramatically in this during the last 10, 20 years. And at the same time, then the use of mechanical ventilation and high flow nasal cannula has been falling down. So there is clearly a trend in, I would say, in most countries to use more nasal ventilation than invasive mechanical ventilation these days. Unfortunately, as I mentioned before, when you deal with the smallest, sicker patients, there is a much higher proportion of them that require mechanical ventilation. So we still have to consider using the most effective but the safest way of invasive ventilation to reduce lung damage and reduce BPD. And these strategies consist mainly of patient-triggered ventilation, volume-targeted ventilation, and there is also now the use of closed-loop FiO2 control to reduce the inspired oxygen concentration in these patients. So let's analyze briefly what is the evidence. Synchronized ventilation reduces the duration of ventilation. You can see here that there is a lower number of hours of mechanical ventilation when we use synchronized ventilation, and this is because if you are doing synchronized ventilation, you are depending on the respiratory effort, the respiratory control that the baby has, and therefore you are not suppressing their effort, and this favors earlier extubation and reduces the duration of ventilation. In terms of synchronized ventilation and incidence of BPD, there is only one paper by Baumer in 2000 that suggested a lower incidence of BPD. The other study in the same year did not show any difference. So there is no clear evidence that synchronization, although it reduces the duration of ventilation, there is no clear evidence that reduces BPD. There is one study that from a group in San Diego, Bernstein and collaborators, published in '96, so many years ago, that showed that in babies under 1 kilo, extreme premature infants had a lower incidence of bronchopulmonary dysplasia when they were ventilated with SIMV, 47%, versus intermittent mandatory ventilation without synchronization, 72%. This is, again, a relatively small study, 90 patients in total, but suggested that synchronization could reduce the incidence of bronchopulmonary dysplasia. The other mechanical ventilation strategy that has become also much more frequently used because of the possibility of reducing BPD is volume-targeted ventilation. When we are using pressure-limited ventilation, we are giving the same pressure with each breath. If we switch our patients to volume-targeted ventilation, we are essentially giving the responsibility for adjusting the peak inspiratory pressure to the algorithm that is included in the ventilator, and therefore the peak inspiratory pressure will be lower as long as the baby gets the tidal volume that we are setting that ventilator to deliver to that patient. So usually what you see is more consistent tidal volumes and lower peak inspiratory pressures and lower mean airway pressures. And again, similar to synchronized ventilation, volume-targeted ventilation, because it is an automatic weaning method, reduces the duration of ventilation. You can see in this meta-analysis that most of the studies fall on the left of the zero line, indicating that the duration of mechanical ventilation when using volume-targeted ventilation was lower than during regular pressure-limited ventilation. These studies also showed a reduction in BPD. Here, the results are much less consistent. In fact, there is only one study that achieved statistical significance. All the other trials have a similar trend, but they did not reach statistical significance. So anyways, if you see the meta-analysis here, there is a reduction in BPD, and I think that this is the type of evidence that many units around the world are utilizing now, are basing the use of volume-targeted ventilation to reduce BPD. We are really not sure because, again, many of these studies have relatively low numbers of patients enrolled, and many studies use different strategies for volume-targeted ventilation, different periods of ventilation. So we don't think that this evidence is substantial to recommend the use of volume-targeted ventilation in all preterm infants. At least that's the decision we have made in our unit. The reason why we are not willing to start using volume-targeted in all patients is because there are issues with volume-targeted ventilation. It's a technique that requires the proper equipment, and there are a number of things that can make the detection of tidal volumes inaccurate, flow sensor failures, leaks around the endotracheal tube, and this then will obviously limit the efficacy or maybe increase the risk of volume-targeted ventilation if the signal is not accurate. The other thing is that frequently people set the pressure limit at a level that is too low, and then the ventilator cannot generate the pressure necessary to deliver a normal tidal volume. And for us, the most difficult limitation is that it's very difficult to know exactly what is the ideal tidal volume that a patient needs at a certain point during their evolution. And if you use, for example, a tidal volume that is too low, lower than what the baby needs, the baby will have to struggle, increase the respiratory effort because the ventilator will win the pressures. So anyways, we feel that this is an interesting technique, but we think that more evidence is required before one can say that should be used in all circumstances. 2 words about high-frequency ventilation. This was really our hope many years ago in the late 80s and 90s. We felt that because BPD was clearly related to invasive mechanical ventilation and ventilation with large tidal volumes, our expectation was that if we were using very tiny tidal volumes, the incidence of BPD was going to fall. And initially, the studies suggested, in fact, a lower incidence of BPD in babies ventilated with high frequency. But you can see here in this very interesting publication from Ulrich Thome in Germany, that as the time went by, the differences of the potential advantage of high-frequency ventilation disappeared. And most of the more recent trials, if anything, show more benefit with conventional ventilation than with high frequency. This is a very interesting observation. And I think that the most likely explanation for this is that we have learned how to use conventional ventilation. And we are much more careful when we use invasive ventilation. And that's why the results are getting equal or even better than the use of high-frequency ventilation. So we don't think that at this point, again, there is indication for primary use of high-frequency as a preventive method for BPD. Oxygen, lots of this work has been done in Australia, and this is the meta-analysis from the most important trials on different oxygen targets. And as you could expect, the babies ventilated with oxygen targets of 85 to 89 had lower incidences of BPD than babies ventilated with oxygen targets of 91 to 95. Unfortunately, as you all know, the mortalities were higher. The mortality was higher in the babies who were ventilated with the lower oxygen target. So although this seems like a reasonable alternative to reduce BPD and most likely also reduce ROP that was lower with the lower targets. If you have to put in the balance BPD, ROP versus death, I don't think that there is much of a question. And that's why I think today most of the clinicians prefer to use the higher target of 90 to 95%. So summarizing, the respiratory support strategies that have been shown to be effective in reducing BPD are first, avoiding invasive ventilation by using nasal CPAP or nasal ventilation. Second, avoid of excessive tidal volumes by using volume targeting that can be automated or can be done by the clinician by close observation, recording, and adjustment of peak inspiratory pressures to avoid large tidal volumes, or by use of high-frequency ventilation. And the last is patient-triggered ventilation that, as I mentioned, reduces the duration of ventilation and also reduces the incidence of bronchopulmonary dysplasia. So with the application of these relatively basic principles of mechanical ventilation, what happened in most countries is that the incidence of the severe bronchopulmonary dysplasia, the original BPD, has come down even further. But what happens is that the smaller babies has increased, and therefore the incidence of this new BPD, milder BPD, has remained relatively constant, or in fact, there are some reports that suggest that the incidence may be going up now with the higher survival rates of the more immature infants. So I think that the challenge during the next 5 or 10 years is to try to tackle different strategies to reduce this new type of BPD, i.e. decreased alveolarization. And this may be achievable by avoiding prolonged patent ductus arteriosus, by improving nutrition, vitamin A and protein administration, by judicious use of caffeine for extubation and apnea, and by use of postnatal steroids. So we are running out of time, so I will just very briefly discuss some of the evidence for these interventions. PDA, it's very clear that if you leave babies with a significant PDA open for a long period of time, they will have a higher risk of BPD than if you close these PDAs earlier. Now you will see that there is some caveat to this proposal from Ron Kleinman many years ago. And we did a trial, we published a trial 10 years ago now, where we randomly assigned patients to early ibuprofen, patients with PDA, proven by echo, to early ibuprofen or expectant ibuprofen, given only when these babies develop a clinically hemodynamically significant PDA. We were expecting to see a lower incidence of BPD with early ibuprofen. You can see here that this did not happen. In fact, the incidence of BPD at 36 weeks was higher, not significantly higher, but was higher in the babies who received early ibuprofen than expectant ibuprofen. This study had a relatively small number of patients and included all patients with PDA, not only those with a hemodynamically significant BPD. So we attributed these results or lack of effectiveness of early ibuprofen to these study design limitations. However, just a few weeks ago, there was another publication in New England Journal with a much larger number of babies where a very similar protocol was used. Patients were randomized to early ibuprofen or late ibuprofen, and the results were very striking. Actually, they mimic very closely the results that I just showed you, and you can see here that the babies who had early ibuprofen administration had a higher composite outcome of NEC, moderate to severe bronchopulmonary dysplasia or death than the babies who were treated with expectant management. So we really think that this point that early closure with ibuprofen in babies that may have a small, relatively asymptomatic PDA is not a good idea, and in fact may compromise the outcome. What is the mechanism of this deterioration? We have no idea, but I think that at this point there are two trials, and here you can see this trial has more than 260, 270 patients, and exactly the same type of results. So I think that at this point, we at least are recommending in our institution to treat the PDAs only when they are hemodynamically significant. We are not using prophylactic ibuprofen or indocin, and we are not treating them early if they are relatively asymptomatic or have only mild symptomatology. This is in relation to vitamin A. Vitamin A deficiency produces alteration in alveolarization and significant changes in airway epithelium. And there is data in humans for many years now showing that the administration of vitamin A by intramuscular injections to prevent vitamin A deficiency reduces the incidence of BPD. This reduction is relatively small, and that's why many units in the world, around the world, elect not to use intramuscular injections 2 or 3 times per week because of the trauma that is induced by this, and because of the relatively small effect of the administration of vitamin A. The other nutritional intervention that unfortunately there is no solid data, and I don't think that there will ever be, is the effect of maternal human milk in prevention of BPD. Here you see a meta-analysis published a couple of years ago showing in data, essentially this is not prospective randomized trials, but is post hoc analysis of data showing that those babies who were fed their own mother's milk exclusively had a lower incidence of bronchopulmonary dysplasia than those babies that received either complete formula or even when they received partially feedings with formula. So interesting data. Again, I think that there are so many other reasons to give human milk to these babies that nobody will ever dare doing a prospective randomized trial and eliminating the possibility of one group of babies not receiving human milk. Caffeine, a couple of words. We all know very well the study from Barbara Schmidt and collaborators, the CAP trial, that showed a relatively unexpected result of a lower incidence of bronchopulmonary dysplasia in babies who received caffeine for apnea or extubation versus the placebo infants. We have been very concerned about this and did a prospective randomized trial comparing early administration of caffeine during the first 3 days of life versus control caffeine for extubation or apnea afterwards. And again, we were expecting to see shorter mechanical ventilation in those babies that were started on caffeine during the first 3 days and a lower incidence of BPD. Surprisingly, the incidence of severe BPD was exactly the same, and severe BPD of death was also the same. If anything, was higher in the babies who received early caffeine. So we were very surprised with this, but not so much because essentially the indication for caffeine where there is clear evidence is for extubation and is for apnea. There has never been a study that shows that giving caffeine to babies who are on mechanical ventilation and therefore do not have severe apnea does anything good. And in fact, there is this trial that is a retrospective, excuse me, this is not a trial, it's a retrospective analysis of data from a very large database from pediatrics here in the US, more than 10,000 patients, where they analyzed babies who received early caffeine during the first 3 days or routine caffeine after the first 3 days. And you can see that there is no difference in BPD, 13% in the early caffeine, 11% in the routine caffeine. So our interpretation is that really the caffeine is a fantastic drug, very effective for preventing the need for reintubation, very effective to reduce apnea, but we don't think that there is evidence for the use of caffeine in every single baby, even when they are intubated and mechanically ventilated. A few words about steroids. Postnatal steroids clearly reduce the improve lung function and reduce the incidence of BPD. This is using hydrocortisone, budesonide, dexamethasone. But as you all know, there are a number of acute negative effects: hyperglycemia, leukosuria, hypertension, cardiomyopathy, and the most concerning side effect is abnormal neurological development, with a clear increase in the incidence of cerebral palsy in babies who are treated with postnatal steroids for long periods of time and high doses. So that's why people have tried different alternatives. One of them is the use of hydrocortisone, and the results of these trials have been really not very conclusive. This is the latest study in New England Journal of Medicine, published a few months ago by Christy Waterberg, who has been pursuing this question for many, many years. And she did show that babies treated with hydrocortisone for 10 days came off mechanical ventilation sooner than the placebo, but she did not see any effect on survival without moderate or severe bronchopulmonary dysplasia, 16% in the hydrocortisone, 13% in the placebo. So no beneficial effect, but no concerning effects. And this is important because other trials have shown GI perforations occurring at a higher frequency in babies who are treated with hydrocortisone. So in terms of postnatal steroids, I think that the big question now is whether these results published many years ago, 7 years ago now, by Ye and collaborators, showing that budesonide given with surfactant produced a significant reduction in the incidence of BPD or death. You can see that severe BPD came down from 19% in the control who received surfactant alone, compared to the budesonide and surfactant, 9% only. Again, there are many trials going on now that are trying to reproduce these results. If they are in fact proven correct, I think that this will be an intervention that clearly will be effective in reducing BPD. Ye followed a subset of the babies that he studied in Taiwan and Chicago, and he, reassuringly, he did not show any alteration in neurological development in the babies who got these 1 or 2 doses of surfactant with budesonide. So we have to wait for the trials, and hopefully they will reproduce these results, and this may be a very effective strategy. So the issue with postnatal steroids is the right indication. We have to use it only on babies that have severe enough respiratory failure, not in milder cases where we are going to cause more harm than good. The age of treatment, there is some evidence that very early treatment with steroids other than budesonide can also have more deleterious effect on neurological development. Don't know exactly which drug, which type of steroid, and dose and duration of administration are the most appropriate. And again, I think that we have to be concerned with the long-term side effects. 2 words about stem cells. Our laboratory, Dr. Karen Yang and Shu Wu, have shown now for many years that the installation of stem cells in the trachea of animals exposed to 100% oxygen improved alveolarization when compared with animals that received only placebo. Based on these studies and those of many other groups that have shown similar improvement in lung development with stem cells, Dr. Yoon in South Korea and collaborators have published now 2 trials. This is the last one, is a phase 2 trial where they showed that there was a significant reduction in inflammatory mediators in tracheal alveolar fluid in babies who were treated with stem cells. And there was, again, some improvement, some reduction in moderate or severe BPD from 73 in the control, 73% in the control, to 32%, excuse me, 73 to 56% in those babies who received mesenchymal stem cells in the trachea. And severe BPD was also reduced from 53 to 19. But you have to, again, realize that there were only 31 babies included in this trial. So this is a early phase 2 trial. We have to wait for other studies that enroll a larger number of babies and follow them for longer periods of time before this very complex and with some risk therapy can be recommended routinely. So to finalize, repeating again some of the points, established strategies to prevent BPD are less invasive ventilation, volume-targeted ventilation, avoiding excessive FiO2, caffeine for extubation and apnea, vitamin A, and postnatal steroids. There are a number of other trials going on. One is with mesenchymal stem cells. There are, as I mentioned, trials trying to see if surfactant and betamethasone reduces BPD. There are always trials going on with different strategies to manage the patent ductus arteriosus. Insulin growth factor is being also trialed now as a way of reducing bronchopulmonary dysplasia, and azithromycin in babies who are colonized with uroplasma. There are trials, very small numbers, so there is no clear evidence that this therapy that does eradicate uroplasma, but there is no clear evidence that reduces BPD. There is one interesting trial published a year ago where these investigators showed that N-acetylcysteine given to babies born to mothers with chorioamnionitis reduced the incidence of BPD, probably by reducing inflammation and oxygen toxicity. So again, this is only one trial, so hopefully there will be others in the future that will tell us if this is reproducible. So is BPD preventable? Well, lots of people, including this study from this data from the NIH network, suggest that BPD is going up. I'm really not convinced that BPD is going up. If it is going up, it's usually because we are using different definitions of BPD, and also because we are having smaller and smaller babies being treated in our units, and obviously these babies have a much higher risk of bronchopulmonary dysplasia. This is a study that was recently published by a group in California showing the BPD in all the patients who were born in the state of California from 2008 to 2017, and the yellow curve shows adjusted, BPD or death. And you can see that there is variation from year to year, but there is no clear trend either up or down. In our institution, if anything, we have seen a reduction in BPD, in severe BPD, during the last 10 or 12 years. So I don't think that, again, we have to be really concerned. I don't think that the increase in BPD is real when you adjust for risk factors, especially for gestational age and birth weight. Again, I just want to finish saying that BPD is a very complex disease, clearly multifactorial, many things that we have to consider. So the only way of reducing this complication and having an impact is dealing with as many risk factors as we can, including antenatal factors and postnatal factors. I think that this will be the only way in which we will improve not only lung outcome, but this applies also to many other diseases associated with extreme prematurity. Sorry to take a few more minutes, but this has been an interesting topic for me for many, many years. So it's not easy to give up. And I think we all have to continue to work very hard to improve the outcomes of our kids. Thank you very much.
Thank you so much, Eduardo. You're going to be hammered with questions. If you look at the chat pane, we've got 3 comprehensive questions at the moment. So the first one is probably from John Smythe, right? So John, you're asking what Eduardo's unit does for the approach in early extubation in less than 28 weeks infants, because we're all concerned about the risk of IVH and neuroprotection if the babies are unstable after early extubation. What is your take on that?
Yes, this is one of the things where we really have failed. We are constantly revising our extubation criteria and trying to assure that our fellows and trainees in the unit do everything possible to extubate babies as soon as possible. And unfortunately, that's the issue, that the price for early extubation is higher rates of failure of extubation. And failure of extubation, it has been shown very clearly that it's not benign. It is associated, or it can be associated with higher incidence of IVH. It can be associated with deterioration in respiratory outcome and higher BPD rates. So this is a question that unfortunately we have not answered. Lots of people are working on better criteria for extubation, but so far we really don't know what is the ideal time for extubation. So we don't have any magic bullet or any magic answer. We just use similar criteria to what everybody else uses. Usually we wait until the baby is on 40 or less % oxygen, until they have a relatively normal or not normal, but acceptable PCO2. And this is important because if we wait for a normal PCO2 in a baby with chronic lung disease, we'll never extubate them. So in those babies, we have to tolerate slightly higher CO2s. And caffeine for extubation obviously is very effective. So I think that's a criteria we use in our patients. And we have a relatively low incidence of extubation failure. But again, that makes us think that we probably are keeping babies longer than what they should be on a ventilator. It's a very difficult decision, and we hope that in the future there will be better answers to decide when to extubate. By the way, the same problem happens with adults. There is constantly literature coming out describing different algorithms to extubate adults who are on invasive mechanical ventilation.
Thank you. And from Martin Kluko. So Martin, I think your question, so correct me if I'm wrong, is can you give earlier DEX to stop the babies from being re-intubated after initially stabilizing with CPAP and surfactant? Is that right? Or intubated after CPAP? Thanks.
Yeah, thanks, Julia. I mean, there's a little bit of a practice creep. Eduardo, thank you very much for the talk. Very comprehensive as usual. Nice to hear your voice again. The question was really around. There's been a bit of a practice creep where we have babies in our unit who may have had an initial reasonable course, and then by 2 or 3 weeks have deteriorated and are in rising oxygen, and they're heading towards being on a ventilator. And we can see that they probably then will require steroids to help them off the ventilator because of the degree of lung change they have. So there's been a bit of a practice creep to start steroids before the baby actually goes on a ventilator. Is that a good idea? Is there any evidence for that? Would that reduce BPD by avoiding a first or a second episode of mechanical ventilation?
Yeah, I think it's a very reasonable approach. Usually, we don't give dexamethasone to a baby who's extubated because, again, we are worried that will increase substantially the number of kids that will be receiving steroids. But I think it's a reasonable approach. When I say we don't use it, with one exception, if we have a kid that we extubate and we see that he clearly has upper airway obstruction because of prolonged intubation, then we will use steroids before we have to re-intubate, hopefully.
Yeah.
But at this point, we are treating only babies who are stuck on the ventilator, and that we think that the improvement that we are going to induce by giving the steroids will allow us to get the baby off the ventilator.
Yes, I saw you flipped through Lex Doyle's slide of the comparison of trials and looking at the baseline rate of BPD in the placebo group. And I mean, I think that's very instructive, and it's a matter of understanding what your percentage of risk of BPD is at a particular point. And there's benefit if you give steroids with a high rate of BPD, and harm if you don't, and try to divide the patients. What is that division point? I think in that paper it was around about 66% chance of having BPD, so about 2/3 of the chance of having BPD versus 30%. So
I'm sorry I had to run. That is a fantastic slide showing essentially that steroids are good when they are indicated, but they may be very bad if we are giving them to babies that may make it without the steroids. So
thank you.
I'm glad you brought that up, Martin. It's good to see you.
Thank you both. Okay, next one's from Srini. Srini, very long question. Can you announce yourself? The 23-24 weekers. You're mute.
Sorry, Julia. I think thanks very much, Eduardo. That you have partially answered my question in the first one. Essentially, what I was asking is that, like some of us always discuss about if you have a 23-weeker or a very tiny baby, 400 gram or 500 gram, like whether we should follow the LISA or MIST or INSURE for them as our standard strategy, or we should leave them ventilated for 4 weeks, 5 weeks. There is always this argument, well, in our unit as well, and I'm sure it is happening in other places as well, because we have been to Japan. Japan has got a slightly different way of ventilating and caring the babies. The overall nursing care and everything is different. So just wanted to get your thoughts on it.
Yeah, no, I think that, again, the chances for a 23, 24, 25 weeker to come off the ventilator within a few hours or days or soon after surfactant, I think they are very slim. You may be able to get them off the ventilator for a few hours, but most of them will need re-intubation. So I think that this is a very good point. And I always tell, INSURE is great for a 27, 28 weeker. Those babies have good respiratory control. They have a more stable chest wall. They have better lungs. So those babies have a very good chance of coming off ventilation. So we load them with caffeine and get them off. But in a 24 weeker, I always tell them, again, INSURE most likely will fail. You pull that tube, that baby will not make it. So in those kids, at least we wait much more than what we would wait in a larger kid. Even if they wind down to room air or very low FiO2, these babies fail not so much because of lung failure, but because of respiratory control issues. So clearly, gestational age is the main factor that one has to keep in mind in terms of deciding when to pull the endotracheal tube.
Okay, thank you, Eduardo. We might just take 2 more questions from best friends, right? Peter and Fanny from China. So Peter Dargaville, good morning. It's tennis day in Hobart, right? I have never heard of RIP. Can you, what Peter is alluding to, oh my God, he's not playing tennis. Lovely.
No, not yet. That's later. Hello, Eduardo. Thanks for your talk.
Peter. How are
you?
The
question's pretty simple one. Yes, very well, thanks.
RIP.
So I think everywhere around the world, people are struggling with what to call the disease that emerges in the second and subsequent week in the life of a preterm baby, which we call evolving BPD or emerging BPD. And it's probably a mixture of inflammation and edema and structural damage, as you alluded to. And you've written with Alan Job a great review on this in 2012, and you called it respiratory instability of prematurity. I think that this is the disease that you were referring to. And we don't tend to use that term because the acronym is RIP, and we don't like that acronym.
Exactly.
And so do you have another term? Because evolving BPD is not a great term. And in fact, many babies who we say have evolving BPD then don't end up having BPD by definition because they're out of oxygen at 36 weeks.
Yeah. Well, they still probably have BPD. If you look at those lungs, I'm sure they don't have the normal complement of alveoli and capillaries and everything. So that's the issue, that, you know, how do you define BPD? And it's again, we would take many hours discussing that. Yeah, this RIP, we were very naive with Alan. We didn't realize what we were doing, calling it RIP. But I think that essentially we were trying to find a good term to describe these babies that are not old enough to say, yes, you have it, but clearly they were going that way. And at this point, we don't have any term. We just call them evolving BPD. And unfortunately, again, it's I think that it doesn't make much difference how we call them. I think we all know what they are. These are the kids who are stuck either on non-invasive or on invasive ventilation, but they have relatively mild disease. And they may not fit any of the criteria for BPD, but as I mentioned, these kids all will have some degree of abnormality, and most likely they will have increased respiratory illnesses after discharge and so on. So again, here we get into the dilemma of how we define things, and this is another area where I don't think that we are going to agree very soon, because every few months we have a new definition, and yes, they are all fine, but I think that if we keep changing, we will never be able to have any meaningful statistics or meaningful endpoints also for research. And here in the evolution towards either healthy lungs or BPD, I think that we don't have a good name other than evolving.
Yeah, thanks, Eduardo.
Thank you both. Just one last question from Fanny in China. She's probably asking the same question. So they've got like a preterm baby about 25 weeks, extubated, and then have to be reintubated a couple of days later. Do you recommend that? I think that's what Fanny's asking, Fanny. Yeah.
Hello, Julie.
Hi, Fanny.
Hi.
So is that what you're asking, Fanny? The reintubation.
Yes. We just faced some preterm babies that the gestation age is low, and in the first week we found that the blood gas is good and the support of the ventilator is low, but most of the time we just extubated the baby, but failed 1 or 2 days later, and it will do great harm to the baby.
Yeah, what you're saying is that
you're worried about fit for the baby. Just give ventilator, not a non-invasive ventilator. Yeah, I just think that in Professor, in your talk, you suggest that for the baby prevent BPD, so we need to use non-invasive ventilator. But for the extremely preterm baby, I think maybe in the first week, invasive ventilator may be more suitable for this kind of baby.
Yes, as we mentioned before, I think that in the baby who is very immature, even if they don't have severe lung disease, the chances for successful extubation are much less. So I think that in the more immature babies, we will clearly wait a little bit longer. And then those are the babies that after we extubate, or before we extubate, we will load them with caffeine. And I didn't discuss it here, but there is some data showing that higher doses of caffeine is more effective in preventing the need for reintubation. And then we would use nasal ventilation. And again, this nasal ventilation, one thing is just to say nasal ventilation, but you can have different degrees of support when you are using non-invasive ventilation in terms of a rate, peak inspiratory pressure, and so on. And hopefully we will have synchronization in the future, because again, that may make a difference in terms of the effectiveness of non-invasive ventilation. One thing that I didn't mention is that we don't know why nasal ventilation is more effective than nasal CPAP. We think that it's because we are ventilating, but the truth is that if you do measurements of tidal volumes during nasal ventilation, you don't see much gas entry or much increase in tidal volume with the nasal ventilation. So we did a trial a couple of years, 3 years ago or 4 years ago, where we compared different levels of CPAP after extubation, 4 to 6 versus 7 to 9 centimeters of water. And surprisingly, we saw that these babies who were being extubated to the higher level of CPAP did much better than the ones that were extubated to the usual standard level of CPAP. So this makes us think that part of the benefit of nasal ventilation may just be the fact that we are using a higher mean airway pressure, not so much that we are really ventilating them. But again, this is just a speculation, and it's something that needs to be studied. So I guess the message I'm telling you is that for any reason, you cannot use nasal ventilation and you are extubating a kid who still has some degree of lung disease, try higher CPAPs. And I'm not talking about extubation during the first day. I'm talking about babies who have been on a ventilator for several days. If you use higher levels of CPAP early, you may end up with more air leaks, more PIE, more pneumothorax. So I'm talking about later extubations when the babies already have some degree of lung disease. And in those situations, then a higher CPAP, 6, 7, 8, or 9, can improve your chances of successful extubation.
Thank you. And maybe one last short question.
Yeah.
Short questions. Thanks, Fanny.
Thank you.
In treatment of BPD.
Yeah.
Eduardo, prednisolone in BPD.
Prednisolone in BPD. I don't have any data, and I don't remember at this point any publications with prednisolone.
I think that's also a practice script. Ravi is absolutely right. I think the respiratory physicians seem to be putting the babies on, the older babies, on prednisolone nowadays. Yeah.
Okay, so you're talking about before discharge.
Or even at home, yeah.
Yes, yeah. That, you know, our you know, every time we discharge a baby with BPD, we consult with the pulmonologists that are the ones that follow our patients after discharge, and they use diuretics, bronchodilators, and all sorts of steroids. Now, the evidence for that, I have no idea. I don't know of any clear evidence that it really helps.
Okay, I think so. So Rory, no answer to your question, I'm sorry. All right, so we have maxed out our time, Eduardo, and it's very late for you now. So thank you again. That was an amazing talk, and we'll send you the recording to quickly have a look at to make sure you're happy with it. And if it's okay with you, we'll post it for people to view on our WhatsApp group.
Perfect. Thank you very much for the opportunity to talk about BPD, and it's nice seeing you all.
Thank you. Take care. All right.
Next time in Australia.
Definitely. Rahul will take you for a swim. All right.